Hey guys, Dr. R here. In this video, we're going to talk a little bit about our headache differential. So we'll talk a little bit about the tension headache, migraines, cluster headaches. We'll talk a little bit about pseudotumor cerebri and trigeminal neuralgia, just because they can sometimes fall into these, very similar presentations. And so we'll compare all of these and then kind of figure out what are the key things that we want to look for when we're differentiating these different diseases. So we'll start with the tension headache. And, one thing I want to preface with, when we talked about the different dementias, we said, okay, well, what are the early findings? That's really going to help us differentiate Alzheimer's dementia from Parkinson's disease, from Lewy body dementia, etc. When we're talking about headaches, the key thing you want to look for are these descriptive words. I'm just going to put one here. So this is the number one thing. It's really the way that they describe the headache and the location of the headache that's very classic. Some other things that we're going to look for are, is there neurologic signs? Is there any nausea? Is there any vomiting? And then how long do these symptoms last for? If you can figure out those three things, usually you'll be pretty close to right on the money with what we're talking about. Again, talking about the tension headaches, though, tension headaches are the most common form of headache overall. Okay, and typically these are going to be described as a band-like, bilateral, achy, tight, or dull headache. Okay, so again, the band-like is very classic. When they use this term, they're pretty much referring to tension headaches. It's very rarely that it would be anything else. And bilateral is also classic. When you're talking about migraines, cluster headaches, typically those are unilateral. So this is one way to differentiate yourself. And then also vice-like, almost like the head feels like it's in a vice. That's also classically used to describe tension headaches. And another kind of way that they will say this, instead of saying bilateral, sometimes they'll say bifrontal. Okay, this is also, very classic in the frontal region, usually on both sides. Okay, and again, very tight, dull, achy. Sometimes that pain will kind of go down into the neck region, near the sternocleidomastoid or in the shoulder. Okay, so it's also common to have this musculoskeletal tenderness, but it's really important to note that there's really not, neurologic symptoms, at least not in a classic case of a tension headache. Okay, of course, everything that we talk about, in some cases there might be an exception. But in general, when you're thinking about tension headaches, I want you to kind of think of it as having no real neurologic symptoms, especially in a board question. It would be very, non-traditional to see that. And so this is going to, again, help you differentiate this from, things like migraines, for example. Now, the duration here is actually pretty interesting with the tension headaches. So the duration can be, 30 minutes. It can be years the person can have a tension headache for. Okay, so, this is not something that will typically be used to tell you that the patient has a tension headache. We're going to use the duration to distinguish cluster headaches from migraines. Trigeminal neuralgia has a very short duration. So those ones are more important to look at the duration. But the big thing for the tension headache is really the bilateral nature of the headache. Okay, that's very important because most of the other headaches are unilateral. And then again, like we said, the classic descriptive words are something you want to remember. Now, in terms of the triggers, there's nothing that's, super classic. I mean, you would suspect stress to be a trigger. This isn't going to tell you just because a patient is stressed and they have a headache, it doesn't mean that it's a tension headache. It's just one of the more common causes. Okay, lack of sleep, anxiety, all of these can provoke headaches. They can also provoke seizures. Okay, that's particularly how you'll remember as well. And associations, when we're talking about the associations, there are some very specific headaches that you want to know the associations for. Tension headaches is not one of those. Okay, but I put it on here anyway for your review, but not particularly how you'll remember this. And generally, there's really no genetic predisposition. So the associations, these are going to be more important when we talk about migraines. Okay, but just put them on here for your review nonetheless, since we're comparing a lot of the similar features between these headaches. And when we go to the management, it's pretty conservative overall. I mean, you can use NSAIDs in these patients, but again, step one, they don't ask a lot about, which management, what drug you want to use. It's more so about different mechanisms and correlating the side effects of the drugs. So again, here it's pretty conservative, not particularly high yield. The big thing I want you to remember, like I said, is how they describe tension headaches, because, these are the terms you're going to have to use to figure out what's going on with your patient.